There are lots of lights and sirens emergencies in pre-hospital medicine, of course, but this is one where the child looks very fine. You're like, why am I rushing? And you need to put the foot on the gas, literally and figuratively. So our time to, we talk about door to balloon time and stuff. We don't have it officially made for batteries, but from time of ingestion to removal, under 2 hours is like what we're always shooting for.
Welcome, you two. Do you mind introducing yourselves?
So my name is Noufal Jahdali. I'm a Pediatric Emergency Fellow at the Hospital of Sick Children.
And hey, everyone. I'm Dan Rosenfield. I'm a pediatric emergency physician at Sick Kids and an injury prevention specialist and chair of the Injury Prevention Committee for the Canadian Pediatric Society. Pleasure to be here.
Yeah, you both have amazing backgrounds, like extensive experience. Because Nouv, you're from Saudi Arabia, correct?
Yeah, that's correct. I have done my pediatric residency back home and pediatric emergency fellow, which are about 6 years of experience in pediatric emergency backgrounds. And also I have been doing pediatric emergency practice, like practicing as a physician for around 3-4 years before moving to Canada.
I got to know, what's the major differences between here and Saudi Arabia?
I would say typically the age group of the patient who presented to the emergency department. In Saudi Arabia, we see pediatrics patient up to 13 years of age, while here we're able to see patient up to 18 years of age. And a lot of adolescent age group here in our emergency department, not much in back home.
Interesting. How come there's a gap between the ages, like 13 there and 18 here?
I think it's related to our cultures rather than just evidence-wise.
Well, and interestingly, Ryan, in the States, the pediatric emergency goes up to age 21. So depending on the hospital you're at, the location, your pediatric range can be quite wide.
That's so interesting. Why 21 there?
That's the age of drinking age there. I don't actually know the firm rules for why. I think I imagine in Saudi, maybe it's for pre-puberty, post-puberty probably makes the most sense from a physiologic perspective. In our trauma setting, we actually cut the age at 16. For mostly, again, from a physiology perspective, you can treat most of the 16-year-olds like adults, and so it makes sense to have them taken care of there. And obviously, the younger they are, the smaller they are, the little more equipment you need and stuff like that.
Well, I got to know from both of your perspectives, because I'm sure you've heard this millions of times in your career, is it takes special people to focus on pediatrics. What both you got into pediatrics?
I would say I choose pediatric emergency in general because I love to work by both hands and mind at the same times. So in pediatric emergency ward, we're seeing a wide range of cases, which is most of the time not limited to one specialty. We're seeing endocrine patients, we're seeing GI cases, and etc. And also we're performing a lot of procedures, which include airway intervention, lumbar puncture, and etc. This is why I choose pediatric emergency as my future career.
And I love pediatrics just because of the kids. Let's be real.
Yeah.
They're a lot of fun. Most kids don't feel sorry for themselves. They, if they're anxious, it's understandable. A lot of people don't like the fact that you have to treat a whole family unit. I think most of us in peds are drawn to that. You have typically built-in allies who can help look out for families. There are tough cases, of course, but you don't get high fives from most adult patients when you reduce their nursemaid's elbow or stuff like that. So there's some pretty fun aspects of pediatrics specifically, and that's definitely what drew me to it. And I think a lot of my colleagues.
Well, good for you two, because it takes a lot of mental bandwidth to deal with this younger patient with distinct physiology and also the family that I'm sure is quite anxious, and understandably so.
Yeah.
And Nouv, you mentioned airway management because that bridges exactly what we're going to be talking about today. So give me an overview, please and thank you, Nouv, of foreign body airway ingestions, specifically in the pediatric population.
foreign body ingestions, which is count for a huge chunk of patient who presented to emergency department. And like 2/3 of the patient will present it to the emergency department with the foreign body. They will be under age of 4, and 98% of them will be an accidental ingestions. So up to 90% of foreign body will pass spontaneously without any intervention, but around 10 to 20% of the foreign body will need an intervention such as endoscopy removal. And unfortunately, around 1% would require surgical removal. For emergency department, two important foreign body that we need to deal with them immediately is the bottom battery and multiple magnets.
I was just going to say the other thing to keep in mind for foreign body ingestions in kids is you actually have kind of a bimodal epidemiology. So you're going to see a real bump when kids are starting to be crawling and moving and they put everything and anything into their mouth. And then you also actually have another peak depending on what it is in the adolescent years where kids are experimenting with different things. Sometimes they're purposefully ingesting, sometimes they're not. So we do see that as well. And that's kind of an interesting element to ingestion. But the vast majority, as Noof alluded to, are going to be in your toddler age group. It's going to be unintentional ingestion. They were, just exploring as kids developmentally do at that age.
Yeah, because correct me if I'm wrong, between 1 and 2 is the peak because they get that oral fixation and they're just so curious with the world. And of course, their anatomy is different. But for the adolescents, that's an interesting point. Can you give me an example of what they would unintentionally ingest for this experimentation?
Yeah, I'll give you one, and then you can fill in a couple others. The classic example I have for magnets that we talked about is, and we'll talk about this a little bit more later. These mini magnets, kids and teens would try and make pretend tongue studs out of them. So they put one on each side of their tongue, and then of course, whoop down the hatch, and they've swallowed 2 of them. You also have autistic teens who are just, again, they also have the kind of the same developmental stage as a younger child. And they just put things in their mouth when they're not observed. Or as some kids with pica or other kind of medical conditions that cause them to kind of ingest a lot of either food or whatever's around.
So pica, describe that for me, because I've seen this in 2 patients and it's a very serious disorder.
What did you see when you saw it?
Oh, this one patient obviously had this excessive urge to eat anything, and he was basically in a room that took everything he could eat away. He actually ended up eating his diaper. And that's a hard thing to treat.
I'd say, Ryan, your case is pretty extreme. Certainly if you're at that level, I'd like to think you've been investigated and treated, but there are kids who have other, if they're certain mental health conditions as well, and those become very extreme and difficult to treat. But I think we're diverging a little bit from where we started.
All right, so let's start with batteries then. How common is that if somebody ingests a battery?
I would say it's pretty common, especially like we have noticed nowadays we're using a very strong button battery around us, like at home, and a remote control of the TV, and with some toys, they're utilizing the small button battery, which can be easily ingested by the small kids. So I would say it's more common than like previous days. We see a pretty bunch of patients in emergency department every now and then.
Yeah. And we're going to talk about this more pretty soon, but there's a major distinction between traditional batteries, traditional, little lithium ion, like AA, AAA, D batteries, whatever they are, and button batteries, both in terms of frequency of ingestion and, more importantly, danger to you if you do ingest them. The reality is historically kids didn't ingest the traditional batteries because they're just too big. So, swallowing a AA battery is actually quite difficult to do. We've seen this, but it's not the same as button batteries, which have just increased in prevalence in product, as Noof said, in products across the spectrum, and we see much more of them. There's not a good epidemiologic number of how many we're seeing, but we know the trend is just kind of linear upwards.
That's so interesting. And this all came together on the weekend because I knew we were doing this, and I was barbecuing. I was looking at my meat thermometer and the back fell off and a little circle button. And I'm looking at this. I'm like, this should so easily fall out and my daughter could just eat it. And I can see how this happens. And how Noof mentioned, the vast majority of them are unintentional ingestions. And I'm sure it's hard to navigate the patient themselves and just the guilt the parents or caregivers would feel that this happened. Because as parents, all of us, it's so easy for 5 seconds to turn your head away and look over and they've done it. How do you navigate those situations?
I mean, I can tell you my approach, and you can jump in if there's anything different. The first thing I do with families is I make sure it's a guilt-free zone. As you alluded to, there's no blame here. There's, unless they fed them the battery, in which case, yes, there's probably blame. This happens unintentionally. Kids are exploring, and as you alluded to, these batteries are completely ubiquitous now in everything from meat thermometers to hearing aids to remote controls to everything. And it actually speaks to something I imagine we might touch on later, which is actually how you prevent this at a systemic level. And this is when we talk about having, I don't know if you've opened button battery cases lately, but they've actually, thanks to a lot of advocacy work, completely changed the packaging to make them almost impossible to open. And that actually creates a whole other adult emergency problem, which is people cutting plastic and then cutting their fingers, which we've actually seen a huge spike in those injuries as well. But that's the reason for that, is to not have batteries being ingested. Some of the companies have played with putting special coatings so that the batteries taste terrible, so the kids would spit them out if they ingest them. Hasn't been fully adopted yet. And of course, the most important thing, I guess your meat thermometer doesn't have this, but most things that contain button batteries are now mandated to be screwed in. If they have any children's toys, they can't be easily removed. They have to be in basically tamper-proof, really annoying for adults to take out and change battery type of system, but it's obviously clearly made for the right safety.
To be honest, once we have a patient presented with bottom battery, most of the time they're in a critical situation. So we don't spend a lot of time in prevention manner, but we need to keep an eye, upon discharging patients with the bottom battery ingestions to highlight the parents how to prevent the reoccurrence. So such as securing the household items, remote controls like thermometers in a very child-proof drawers or cabinets out of reach from a child itself. That will help prevent the reoccurrence. Also, most of the time when we put our child in the play tummy times, especially when they start discovering, we want to make sure it's safe environment around them from any other hazards, including magnets, battery, coins, and even small particles.
So you both mentioned it. It's basically prevention is the cornerstone, because focusing in from a system lens, it's hard to get the batteries out. That could prevent choking, and just prevent reoccurrence is so key. So if we make it operational, let's say a 3-year-old comes to your emergency department, they swallow the battery from a TV remote. They're drooling, they're refusing to drink, they got mild neck pain, and we'll say it's a 20 millimeter lithium battery. Let's say they ingested it 15 minutes ago. What's your first thoughts, Nuv? What are you thinking with this?
So in general, I would like to make sure this patient is stable, his airway is maintained, his breathing is maintained, going through the pulse protocols. And once the patient is his primary survey are stable, we can proceed with our secondary survey, which contain an X-ray, AP and lateral, trying to locate the foreign body and to make sure it's a bottom battery, not something else like a coin, by seeing the double rims of the bottom battery. And it's very, very important that to highlight here that the bottom battery in esophagus is a time bomb, because these 20 millimeter lithium can create an electrical can lead to perforation of the esophagus within within an hour. So immediate intervention by keeping the patient in VO, trying to secure IV, keep hydration, and communicate immediately with the GI for urgent endoscopy removal of the foreign body, especially if it's an esophagus. That's would be our approach. But if the patient was unstable or he do have any active bleeding, that will highlight most likely complication happen from bottom battery ingestions, which could be vascular fistula. So we need to call at that time cardiothoracic surgeon as a backup in case bleeding happen for a repair.
So Ryan, I'll add a few little contextual details to that. So for the pre-hospital audience, This is one of the few, like, there are lots of lights and sirens emergencies in pre-hospital medicine, of course, but this is one where the child looks very fine. You're like, why am I rushing? And you need to put the foot on the gas, literally and figuratively, and work with your local protocols to get this kid to the closest place that can do a pediatric endoscopy immediately. So our time to, we talk about door to balloon time and stuff, we don't have it officially made for batteries, but from time of ingestion to removal, under 2 hours is like what we're always shooting for. And working in the real world, that can be really challenging. But if you know that, or you have a high suspicion of that from the pre-hospital lens, that needs to be patched back to, your dispatch, wherever you're going. And even give the team a heads up if you can, that that's what you're bringing, because there's a lot of logistics. So if you have to do a transfer, if you're in a community that doesn't have a pediatric hospital and needs a pediatric endoscopist, and you need to arrange for air transport, for example, or very fast road transport, that we all know that takes time, and that's time we don't often have. If you have the ability to get to a pediatric center and you can bypass your local center, if that's the way your system works, depending on who's listening to this, that would always be the preferred approach, because a lot of these kids are very small, and very small airways and very small esophaguses are a very specialized niche area. And a lot of community centers will not have the resources from either anesthesia perspective, the equipment, the GI, etc., and that they would need to end up in a pediatric hospital, especially if there are complications. These kids will all get, regardless of even if you get it within 2 hours, these kids stay in hospital, because the damage the battery can do can take hours to days to manifest. So they actually will sometimes go for serial scopes to make sure that that's not significantly worsening. And we'll talk about it later, but even if you get the battery out within a couple hours or not that long, you can still have these devastating consequences up to a week or 2 weeks even later. And so that is an important part of the whole puzzle.
I would say here, Dr. Danny, I will add one point, especially if we're going to transfer a patient from a community, and that will take a time. There is a role of honey that could help passing the bottom battery. It will, like evidence show that it's very useful, especially if you use it within 10 ml every 10 minutes for up to 6 doses for children more than 1 year of age.
And just to be clear, I think it doesn't help it pass the battery, it helps coat the battery so it doesn't conduct as much electricity. The other thing is we did actually release a little blurb last year. Typically, Ryan, you may remember from training, you don't want to give honey to kids under 1 for a risk of botulism. In this case, the risk of the button battery is exponentially higher than the risk of botulism. So it's the one case where we say honey is actually okay. There is a medical version, it's called Sucralfate. Not every hospital has one. If you have that, that's actually preferable. But most people will run to the second cup or the Starbucks in the hospital and get the packs of honey to use those. I've seen that done in community centers while awaiting transfer.
There's so many good pearls in there. And it's funny you say, like, of course, anyone in the pre-hospital setting and like parents would like, oh, so they swallow the battery, it's a rush. But just seeing them seemingly like fine at the beginning, you're like, are they going to be okay? Yeah. But reading into this literature and like what you just described, like if they do have a hemorrhage, that could be catastrophic. If they have a perforation, that could be catastrophic. And the honey thing is fascinating. Like, I didn't know that was one of the main treatments for it.
Yeah, I mean, it's not, again, the treatment is getting it out. These are all temporizing measures, but it's something to do, and it's also a little bit counterintuitive because you're like, well, we got to keep them NPO. But this one is one where most people the evidence is pretty settled. Thankfully, there aren't that many cases to build an evidence base on. But as this increases, we're learning and moving forward. And ultimately, this is all about, I think in Ontario, we're working towards creating even provincial-wide directives on how this actually gets managed, because it's like a stroke or a STEMI. It needs to be, all systems need to be aligned, including the pre-hospital one.
And I want to highlight the points, like how many resources it takes to treat this one patient. Because you said multiple different specialties at specific hospitals, and unfortunately, some places don't have the luxury to have all these resources. So we shouldn't minimize the risk that the batteries could cause. But if we look at a disease mechanism, so let's say the 3-year-old swallowed the battery and the mucosa interacts with the battery. What's going on from an injury standpoint, Nuv?
It will lead to electrical, like I would say, external electrical current that lead to perforation of the esophageal wall.
Yeah, if you want a really dramatic representation, there's a video on YouTube of what happens when you put one of these in a hot dog. I think it's not entirely representative, but just just Google button battery hot dog, and you'll see it's a much more again, podcast format's not the best for it, but check out the visual. It's just like a knife through butter. And so if you imagine that in your esophagus, where it's stuck at kind of mid-level, where your aorta is, where your bronchi are, like very important structures, it kind of is, slowly digging a hole with electric current.
I guess one of the first concerns would be, of course, depending on the battery size, the location, the age of the patient, but are you more worried about it actually leading to that damage instead of it actually leading to an obstruction in the patient, or could it be both?
I would say we are more concerned about damage to the tissue more than obstruction, because it does contain, as we mentioned before, like generating electrical currents, which can destroy the tissue around it, leading to esophageal such fistula, vascular injuries, structure, etc. So we're more afraid about complication rather than just obstruction.
Yeah, and typically most kids, and I know what you might do, maybe I'll do an aspiration episode later, but most kids with foreign body ingestions actually don't have many kind of GI obstructive symptoms. Most of them won't be drooling. Most of them will actually be able to handle their secretions. Some of them will be able to drink, which actually is part of the parcel of the reason this is actually complicated, because you don't actually know that they've swallowed anything because there's no visual evidence for it. So even when we see kids with big, sometimes coins are more common, coins stuck again at their mid-esophagus, they're fine clinically a lot of the time, or maybe an occasional cough. So obstructive symptoms are definitely much lower on your concern list. It's more about the actual thing itself.
All those alkaline ions destroying their tissue, because that can lead to necrosis.
They call it liquefactive necrosis is the medical word for, this soupy tissue app that's been electrified.
Oh, yeah, that's a hard call to deal with. And correct me if I'm wrong, because I read this and you both mentioned this, that if you don't witness the choking or the actual ingestion of it, you could, if they're drooling, like this patient in this case study, it's like, is it an ingestion? Is it epiglottitis? So you can see it's like, what differentials? Because I'm sure you've seen it sometimes. It's like, is this an infection? Then you dive in more and you do some like imaging. And it's like, oh, you got a battery in there. So how common is that?
So to be honest with you, once we have a patient presented to the emergency with drooling, we take a patient as a whole, especially in cases where there are unwitnessed ingestions. So in a patient presented with epiglottitis, he will have other like suppurative symptoms like fever, unwell symptoms. Like he would have another presentation which had been ongoing for a couples of days. While in a foreign body ingestion, most of the time it happens sudden. Like we left our child and we presented there, he was having a drooling, so they picked him up to emergency department. So the acute phase most of the time happened with the foreign body ingestions, also, we want to keep an eye that the age, that we mentioned before, is a patient between 1 to 3 years of age, higher risk of foreign body ingestions, risk. Yeah.
And I think, Brian, that's all a good point. I think you do want to think about foreign body ingestion or aspiration on your differential at all times when anyone comes in with drooling or stridor or things like that. But you're right. In peak viral season, when you've had 5 croups in a row, you can easily, that next one who doesn't have the fever, you're like, oh, it's probably going to spike tomorrow. You can always justify why you do or do not do a particular test. The only saving grace is that most of these foreign bodies, especially the ones we care about, you can see. There's no such thing as a radiolucent battery. They're all very, very opaque. So it's really a kind of a plug for in your community ED or wherever you are to have a low threshold to do an X-ray for like a foreign body series if they're not responding to treatment as you'd expect, or if there's anything fishy in the story. But yeah, to your point, it can be a hard diagnosis to make if you don't have a good story for it.
That recency bias, especially in cold and flu season.
Absolutely.
You can see that could obscure assessments. And I'm just thinking in the pre-hospital setting, and I remember this from school, like the chart of, is it croup? Is it epiglottitis? Is it a foreign body airway ingestion?
Yep.
We always should have that index of suspicion that it could be a choking, because anecdotally, you walk into a house that it's a child patient and there's toys everywhere. You could see it could have been anything.
Yeah, exactly.
So
Well, and
those
that's
are all
again, that's actually really important context, I think, for paramedics to give to when they give the handover to triage to the either triage nurse or the doc to give the context of the house, because we don't see that. And so if they pick up a kid and there's toys everywhere on the floor and they find them in that actually, and they trigger, oh, you know what? There was a mess there. I wonder, could he have swallowed something? And that wasn't what the parent was worried about. That could trigger us as well to do those tests. And that's, again, an area where pre-hospital and hospital communications are so imperative and can actually make a big clinical difference.
So that's a really good point to take away to hammer home. It's like just saying that information, the house was kind of messy, lots of toys, like that could just spark you to do imaging right away. Because from a pre-hospital perspective, it's just making sure you understand where this patient could decompensate in our treatments, but get them to the right place and the right resources if possible.
Well, and the other thing to think about from that end is not just foreign body ingestion, but tox. So if you pick up a kid in a house that's I don't, no judgment here, but if it's in squalor or there's obviously substances around, or you see parents that are altered or things like that, that actually, again, in the kid's presentation is completely different. They're coming in with decreased GCS, or suddenly our perspective goes from, oh, are they sick with the flu, to what did they get into? Are there cannabis edibles on the floor? Is there opioids or other kind of substances? And there's a whole one pill can kill list, and a podcast for another day. But all of those can help. Again, the pre-hospital people are the only people that will really be letting us know, especially if there's no parent with the child or if we're not being entirely forthcoming.
Before we move on to the next case, I would love to know the texture of both your minds from pediatricians' perspectives of if you get a patch in saying ambulance is coming in with a 3-year-old that swallowed a lithium battery, what are you both thinking? Nuve, we'll start with you if you don't mind. Like, what are you thinking in your head? Are you feeling the anxiety, especially being a parent now yourself? Just like, oh, I can appreciate how bad that would feel.
Okay. So I would say that when we are receiving a call, especially from outside, like community hospital, most of the time we would like to anticipate what we would like to do for such patients. Heads up, calling GI. Like, we have a 3-year-old coming with a bottom battery, so we would like to do a full history and assessment and X-ray to confirm the location, but we want you to be aware about this patient. We would like to prepare like airway equipment, especially if the patient was drooling or like there's any airway compromisation. And we will do like pre-arrival handover to the team and to see what things we could do for this patient before they arrive.
Yeah, I agree. So to me, this is a big logistical one. There are lots of things where we need to do something immediately from the ED perspective. There's somewhere we need to call other people. There's somewhere we need to do a little bit of everything. And this is one where, I will absolutely drop what I'm doing and I will kind of liaise with my charge nurse, the triage nurses, because I don't want this kid waiting. If sometimes we've got lines at our triage desk, like this kid is not waiting in line, we're going to bring them directly to a room. We're going to either put them in the trauma room with the portable X-ray. We're going to have ENT and GI on the phone because our service is GI and ENT will often co-manage them. We're going to make sure they have an OR book, because there's also all the downstream things we don't think about. They need to have an OR book, which means they need to have staffing for that OR. They need to, if it's 4 a.m, ENT isn't in house. So we need to think about who we calling to bring in, who did they need to bring in, if the kid is sick or unwell and they need an ICU bed, or, hopefully not, but if they needed ECMO, like there's many steps that if you get the patch call with the confirm of this is the worry that you start, hopefully it's not the case. And I think we do need to talk about that in 1 minute, but that's kind of what I'm thinking. The thing that I want to make sure I don't necessarily leave all the audiences, we're talking about when it's stuck in the esophagus. If it actually passes into the stomach, your danger is not the same way, because there's not that compression of the battery against 2 mucosal surfaces that are very tight. So if that, just like a coin, you can swallow a coin into your stomach and then it will pass. Management of a button battery once it's in the stomach is very different. So not just because I've seen this before, because I take these outside calls where a community physician who's heard talks on button batteries calls us in a panic that they have a button battery in the stomach. And I can always tell them they can breathe a little bit more. It's, I won't say it's past the danger zone. It's not quite, but it's not the same lights and sirens emergency as it is if it's stuck in the esophagus.
This is why medicine's hard. It's always contextual. It could change drastically depending on the location of where like the button is. That's so fascinating.
And also, it's not just the location, also the age, especially for bottom battery. Like if the patient ingested the bottom battery and it's in the stomach already, and he is less than 5 years of age and the bottom battery size more than 20, he needs endoscopy removal, but like not an immediate endoscopy removal. We would say urgent endoscopy removal, and that defined within 24 hours of symptoms. While when a patient more than 5 years of age and he ingested a bottom battery more than 20 millimeter, we could observe him for any like symptoms, and we could go from there. If he didn't pass within 2 days, we could elect to do endoscopy removal at that time. But most bottom battery less than 20 millimeter, they will spontaneously resolve like without any intervention.
So if I'm hearing you correctly, the 20 millimeter size is the golden kind of spot.
Yeah.
Because over that can lead to very detrimental and serious consequences pretty quick. But let's say from a paramedic perspective, they swallow the battery and we ask, like, what's the battery size? And they don't know what was in the toy. What's the best route that we could go down to try and figure that out? Or should we just assume that it's 20 millimeters and up?
I would say most of the toy contain like 20 millimeter. If not, I'm mistaken. I would confirm with Dr. Dan if he had any other knowledge about it. But 20 millimeter is the standard bottom battery used in most of toys, remote controls for AC and etc.
Yeah, my approach in the pre-hospital environment is if you hear button battery swallowed, unless they can show you the pack where it came from and they watch them do that, just get them, assume it's the worst case scenario, because it's just one of these ones where if you slow play it and get it wrong, the consequences are so devastating. Whereas if you don't and you do the x-ray when you get to the hospital and it's not there or it's small or it's past, everyone can relax. But it shouldn't change in the pre-hospital context how you approach it.
Perfect. And I was just thinking from a process kind of visualization, if we mapped out all the resources it would take to deal with this one case, the map would be huge of how much it takes. So to hammer in that point, this is a pretty dire emergency that takes lots of resources.
Yeah, which is why we really focus on the prevention aspect. So I think we're making progress there, but there's lots of room to go.
Well, let's say we get called to a 5-year-old boy who's playing with a little magnet building set. And he's complaining of like intermittent cramping, abdominal pain, respiratory rates 24, SATs 98, heart rate 115, blood pressure 100, over 60, GCS 15. What are we thinking with that? If I patch in, I'm coming in with that. What are you thinking?
Okay, first I will ask, is the patient seem to be very stable for me? How many magnets are ingested? Is it one, multiple magnets? That will make a huge difference in our preparation in the emergency department. Because if it's single, we won't do a lot. We will confirm that once the patient arrives with our x-ray. But if it's multiple, we need to do a lot of intervention, because that put the patient at very high risk for a magnet to stick together throughout the GI tract, leading to a serious complication. So we want to confirm how many magnets are ingested.
So I'm happy to add a little bit more historical context here. This was a residency kind of research project with interest of mine since 2012. The epidemiology of magnet ingestion has changed significantly in the past 15 years, mostly because people have become aware. We've done some advocacy efforts, and now the toys that we're talking about aren't actually allowed to be sold in Canada, but there are lots of them that are in circulation, and so we do still see these ingestions occasionally, but thankfully not nearly as commonly as we did 10 years ago. The interesting thing I will say is Nuf is 100% correct. We have a whole algorithm and paper published on how you manage a single magnet, two magnets taken multiple times at different times in times and space, etc. And because each one can be managed differently. The one yellow flag that I'll say from a pre-hospital setting is, sure, a parent might say, oh, I saw them swallow just the one. What you don't know is, and I've seen this clinically, is sometimes kids, the parents catch them swallowing one and aren't that worried, but for the preceding week, they've been swallowing one every day. And so we had kids who would present with 30, 50, 60 magnets swollen, ingested, and their x-rays were as impressive as they sound. Again, much less common today. And most of the time, if, as you described in kids' toys, the standards are pretty high to make sure that they can't come out of the toys. And the ones that we're talking about, these little desk sets that are now recalled and banned, are much harder to get a hold of. But correct, if it is truly just one, you really don't need to worry. And our level of concern compared to button batteries is much less, because the pathology we care about, two magnets going across the loop of bowel causing pressure necrosis and intra-abdominal sepsis, is a longer drawn out process. So it's not, this will go to the operating room if it needs to, but it's not a drop everything priority one operation. These kids sometimes can get a CT scan first, and they have a little bit more time. Unless, of course, if they're clinically well. If they're very unwell and there have been fatalities in the United States from these types of presentations, then obviously it's a little bit different and they'll go to the OR right away. But it's not quite the same degree of panic, I'll say, as with a button battery.
And you did 2 to 3 papers on magnets, right? Retrospective reviews on this. I was reading them. Well done.
Yeah, it was a good opportunity to shine a light on a kind of up and coming threat, and kind of that's where I got really interested in injury prevention, because this was an area where we could prevent them. We were able to work with Health Canada and other governmental agencies and have them recalled, and you could see in real time when they were pulled back, the incidence of presentations that emerged dropped off. So we, again, don't see them a lot, and I do think that in the last 5 years, a little bit, this was, I'll say, in vogue about 5 to 10 years ago, and everyone knew about it. And I do think now that's actually dropping off a little bit. I've got some residents coming through when I work with them who've never heard of this before, but we absolutely still do see cases. I'll always ask the families at this point, where did they get them? And most of the time it's because they had them from 10 years ago. They're not buying them from even though Amazon sometimes sells them, they're not usually getting them there.
I don't even know what I would think. I'd love to see what you would thought when you saw that x-ray of 30 to 50 magnets in somebody's stomach. I'd be like, this can't be real.
Well, it was so common, and again, and then we call them Magneto. That was a big movie at the time, and that was the ongoing kind of running joke between when the surgical services and the ED is that this was just so common and was so preventable and so silly, which is why we were able to get the word out there and decrease the incidence. But again, we do still see it.
Amazing work. If we pivot and we get called to a 6-year-old, let's say she was eating fish tacos, she was at a picnic, she has throat pain, she's drooling, and her respiratory rate's 20, SAT's 99, heart rate's 105, BP 95 on 60, GCS 15. What are you thinking, Kara?
Okay. So she's eating fish and she started drooling and she have discomfort. Most likely maybe she took a bone of a fish in her throat. So most of the time we observe these children and keep them MPO until further testing done under direct observation for the foreign body. We can do prior to that AP and lateral neck x-ray to see if there is any possible radio opaque foreign body, and then we can go from there. But most of the time, we would like to remove the foreign body in their direct visualization in emergency department. So we call GI team for further care plan for such cases.
And then to add, I think somebody, again, depending on your center, it'll be covered by ENT or GI. The X-ray has variable utility. The majority of fish bones are radiolucent, so we do the X-ray to see if we can see it. But if you can't see it, it doesn't mean it's not there. Most of these kids will get a scope. And again, depending on your center, sometimes that's done by the ED team, sometimes that's done by the ENT team, sometimes by GI. What I will plug for both pre-hospital and ED providers is to take a really good look. I've had 1 or 2 cases where you can actually see the fish bone. Sometimes it's lodged in the tonsil. That one's always an interesting one. And then you have a more interesting discussion of how do you get it out, depending on the age of the kid, right? If they're 12 or 14 and they're compliant, you can, anesthetize them topically with some lidocaine spray and pull it out with McGill's. But if they're younger, that becomes more problematic because they need a comprehensive sedation. And sometimes we do that in the ED, and sometimes we punt that to the surgical services who do that in the operating room. them, because they often might want to take a bigger look, in which case it doesn't make sense to manage it all in the ED. But I will say that sometimes that's an interesting one that you can actually appreciate from a home/pre-hospital setting.
Well, let's linger on that a bit, if you don't mind, because I've heard the story, and this has always stayed in my mind. Depending on what you ingest, whether it's a grape, especially for pediatrics, popcorn, or the worst story I sadly heard was a ping pong ball. And with the McGills, when they tried to grab it, it just kept spinning the ball. So all of the context matters. And I was just thinking from a pre-hospital lens, like if I have McGill's, I'm trying to get a fishbone out, how difficult that would be. Do you both have any tips to...
I would say for a fishbone is rarely life-threatening, so I would not be trying to do that in the field. I think where the cases you're describing, Sam, are like obviously a airway occlusion, in which case you're doing everything you can to get that foreign body out of there. I have never heard of a fishbone causing a airway issue. There are case reports of them eroding into essential structures that are in there, like the button batteries, blood vessels and stuff like that. But I would not be taking them out in the pre-hospital context, because even in a tonsil can bleed a pretty good amount if you take out a sphere that's in there. So we think about that before we remove them and make sure that appropriate resources are available if required. So I probably wouldn't in that specific case. I don't know if you have any other thoughts, but that'd be my
I totally agree, because like the risk of pulling it up like by the forceps, there is also a risk that he will ingest it to his esophagus, and complication could happen with esophageal ruptures or perforation, and etc. So I would keep the patient in PL for further care by the appropriate service for removal.
For my ignorance, let's say you had to intubate like a 6-year-old, 4-year-old that needed to be intubated or do McGill's. How many resources do you have focused on the airway on average, would you say?
We, in such cases, especially in a high-risk patient with the airway like compromisation or airway like risk or difficult airway, we would like to heads up like for ENT team, anesthesia team for a backup. And also, most of the time in such cases, we use the video laryngoscopy rather than just direct laryngoscopy for a better visualization of the airway and for better management. So we will keep one person dedicated to the airway, and the other person will do the procedure and the removal, while the RT will help with the person dedicated for airway in case needed, like for bagging or etc.
Yeah, I think my approach to these cases is really to look at the child as a whole. The reality is most of these are not truly emergent, in as much as they can be done in the more controlled setting of potentially the operating room with the right specialists. Sometimes I'll have discussions with specialists about doing things in the ED versus upstairs. And again, it's all contingent on the patient's stability. If they're not stable enough, then we go ahead with kind of what Noof alluded to in the ED itself. And if they are not, really unwell, or they have we have quote unquote a little bit of time, usually the proceduralists prefer to be in their home space. We know, just like in the pre-hospital setting, you're used to working there, but there's in the patient's house is not as ideal as in the back of your truck. And for us, being in the recess room is better, but the proceduralists prefer to be in the operating room. So you have all of that home knowledge and the team structures that also work in those contexts. So we really try to optimize those if we can, and only if they're truly an extremist do we kind of go down a more kind of fast route.
But overall, if it unfortunately does lead to that, you have multi-specialties and multiple people at your disposal just for that. And I'm just thinking from a pre-hospital lens, it could be 2 paramedics.
Correct. Yeah.
Which is very different.
Yeah.
And last week we spoke about this, knowing your limits, which I thought was a very interesting conversation. Noof, do you mind going first, saying, know your limits when you can intubate and when someone else should intubate or do airway management?
Yeah, to be honest with you, most of the time, emergency department, we handle a patient with a very high risk airway compromisation or difficult airway patients. But once we decide that this patient, there is no other option to wait for appropriate area, such as Dr. Danny mentioned, operative room. So we need to evolve every single patient needed, like care, anesthesia, ENT, all other possible plan. So, and in these kind of patients, sometimes we use fistular endoscopy, alternative like supraglottic device, and etc. So if we don't have other option for appropriate airway management in a very good backup plan.
Yeah, I think it's a really good point, Ryan, to think about. And everyone will have to work within their own clinical confines and think about where they are from the pre-hospital setting down to the tertiary quaternary center, because everyone is going to be resourced very differently. And so, sometimes the best person to do a procedure is the only person to do the procedure is going to be the best person. If you're in a rural setting, we take patch calls and we'll talk to smaller places and smaller towns where they don't have any availability, or our ICU team will talk people through a procedure, or even our surgeons sometimes, because that's the only option. Certainly that changes in the GTA, where most community hospitals in Toronto area will have a lot of specialties, even if they're not pediatric focused. But being aware of what your team and your personal limitations are, the context limitations you have. So you might be able to do a procedure, but now what happens to that patient that you've done this? We talk about this in trauma context. If a 6-year-old has penetrating trauma and there's a surgeon who can do a thoracotomy in Sudbury, but there's no ICU and no OR to take them to afterwards, the procedures probably shouldn't take place. So these are really big, high-level discussions that are completely contingent on the exact clinical scenario you have in front of you. What I always recommend for everyone in these contexts is to reach out. So, being at Sick Kids, we're a phone call away or a critical call away for any of these to offer advice and thoughts on the scenarios that we've seen in the past. There'll be contexts where people will come to me, and I know that I'm not the best person to do a procedure because I work at Sick Kids, and there's a dedicated pediatric otolaryngologist just upstairs who has much more experience doing front of neck airway access, for example. But if I were in a smaller town, it might be me who has the most expertise. So you do really have to think about that in the specific clinical context, in the specific case, and think about all the resources you have available to you, either directly by personal experience or by communicating with others.
Do you think that's hard for even paramedics, pediatricians, any physician to say, I'm not the best person for this, someone else should take this? Do you think that's hard to teach or accept in these dire circumstances?
I mean, in the extreme circumstances, it's actually not that bad because there's not a lot of time. I actually think it's the bubble cases where you can get pretty, where, I don't like using the term cowboy, but people have heard that before in the, pre-hospital emerged space, where people shouldn't be doing things. I think in the pre-hospital space is the evidence, for example, for pre-hospital airway management in kids is actually very robust, that it shouldn't be taking place, with a few exceptions. For example, that airway outcomes are much worse if they're intubated in the community than they are if they're intubated in a hospital setting. And even within the hospital setting, sometimes it's better to do it in the OR than it is to the ED. Like, again, each one of these has a nuance. So the answer to your question is absolutely, it is challenging because nobody wants to see someone get really sick or worse in front of them if they can do something about it. But it's also very hard, especially for these halo events, high acuity, low frequency, to just, sit there and say, well, we'll get them to a hospital. We'll, bag them through it if it's an airway case or something like that. These are very, very challenging. And I will not typically be, judgmental of people's management. They did the best that they could in that context. But it is good when you do have evidence, like I said before, to disseminate that as best you can and give people the tools and the thought process and the critical thinking to think about all the resources available to them in a particular case.
Absolutely. And I'm just thinking, to hammer in that point too, my volume of exposure for pediatric airways is so tiny in comparison to a specialty. I did 5, I think, in the OR, only a handful in my career in the field. That definitely does not make me a pediatric airway specialist at all. It's like trying to go out and golf twice a year. You're not going to do well. And it's such a specific skill. So I can appreciate that.
Yeah, and most things in pediatrics are very similar to that. Even assessing a febrile infant or a kid can look, it's a lot of experience from when we look at a kid and think, are they septic? Are they well? Are they unwell? Are they not? And we're obviously not perfect either. There's lots of, I do look forward to one day when we're accessorized by AI, can help us with other measures, but we're not there yet. And so, it's a lifelong learning for all of us in that space.
Let's say you get called to, or I'm bringing an 8-year-old boy playing with a loose dental crown, and now he has mild nausea, no bleeding or pain. respiratory rate's 18, SpO2 is 100, heart rate's 95, blood pressure 102 and 65, and GCS 15. So you have this object in the gastrum antrum, this large radiopaque object. What do you think about this?
So to start with, this is very, very pretty unlikely to happen, to ingest like a dental crown implant. But if it's happened, it's considered a very large object, more than 2.5, which require endoscopy removal most of the time. But we could accept endoscopy removal within 24 hours before like obstruction could happen, before like worsening symptoms like abdominal pain and nausea and vomiting. So most of the cases who presented to emergency department with such presentation, we will call GI team to see the patient to assess for possible removal within the next 24 hours, to rule out and to observe the sign of intestinal obstruction.
And so just for all listeners, if they're looking to, and if you have show notes, I don't know if you put them, but there's a whole guideline on foreign body ingestions put out by the National Association of Gastroenterology, Hepatology, and Nutrition, or NASPSCAN for short, on basically on what it is, size, whether or not it's likely to come out, yes or no. There's no hard and fast rules. These are very rough guidelines, because when you say an 8-year-old, my son's 6, when he's 8, he's going to be smaller than my nephew, who's massive, and 8-year-olds, and so your development to the size of your gastric antrum and stuff will change. So sometimes, we'll opt to observe these kids. If it's an inert foreign body like a dental crown or a coin or a kid swallow Lego or things like that, then most of the time we prefer to let it come out naturally. Sometimes people do serial X-rays. Sometimes people will, skim through their kid's poop to see if they can find it. But certainly, if we know there's an almost no chance of it passing, if it's a little kid with a massive object, like we've kind of alluded to in this case, then yeah, well, it'll be planned for a relatively expeditious upper GI scope. If there's kind of very low probability of it being removed.
I think that's a really good point too, because that's the problem of pediatrics. You have these rough estimates of their weights, their vital signs, and we get called to a 6-year-old. I'm already doing the equation in my head for their weight and vital signs, and then you walk in and they're completely different size to what they should be, and now you got to pivot.
Yeah.
What's your recommendations for that? Like, how do you prepare for that or adjust on the spot without getting apprehensive?
That's a very good question. To be honest, if we have a patient who ingested like a known foreign body, and we saw the patient and he's completely asymptomatic, and we are suspecting this patient like he needs further imaging and observation, most of the time we call the expertise teams, which is a GI, and we will discuss the case with them based on their expertise. If they based on the history, based on the X-ray finding, most likely it will pass spontaneously without any intervention. We will try to arrange follow-up for such patient. But if the patient develop any symptoms or he show any significant concerns during our assessment, we will call them immediately for immediate intervention. So it's depend on the patient and depend on how he presented to the emergency department.
And I think building on kind of your question about how do you pivot in real time on a patient that you're not expecting, I'll say that for us is almost the norm, because we take care of a lot of what are called complex care patients, or kids who are ex-premature or have genetic syndromes. So they might be 10 years old, but they might only be 15 kilos. So it is a lot about being adaptable and recognizing in real time. And a lot of this, unfortunately, unfortunately or unfortunately, comes with experience. So I've become pretty adept at guesstimating patient weights based on visualization. But at the end of the day, you also want to use your tools. So you have your Broselow tape. I know that's in all of our pre-hospital trucks. So don't feel like you can't change on the fly with what you were going with if you're drawing up meds or things like that. We do that all the time. We have a resus sheet in the ED that's built on a default weight. But if we come in there and they're nowhere near that default weight, I say scrap it. We start again. We're going to change the weight by 20 kilos. You don't want to your earlier point, you don't want to get stuck in a fixation bias or not be able to make changes that you see as you go. So just be aware that is certainly a possibility, and kids will, some kids will be very thin, some kids will be very big. And, the one thing I will say is sometimes people forget that, bigger kids will often reach adult dosing and adult max dosing. And if you use per kilo dosing without recognizing that there's a max, you're going to go way past what's kind of acceptable dosing for a lot of medications. And from the pre-hospital space, I think of like steroids for croup or things like that. If it's a 80 kilo 10-year-old, you're not going to do 0.6 per kilo on 80 kilos. That's going to be like 40 milligrams of dex, which is like double what we would typically give the max dose for an adult. So just something to think about. Like, you never turn off your critical thinking brain in pediatrics, because they'll throw you a curveball every time.
And use the resources that you have.
Exactly.
I always remember walking in and seeing the pediatricians use the Broselow tapes or reference charts, and like, if they're using that, why aren't we using that? And this is all base hospital dependent, but it is written in our medical directives. You can use like Broselow tapes or other pediatric approved things. And just the cognitive offload, just here's the tape, measure it out. There's all the corresponding dosages, even if they may be different from our medical directives, it's still so valuable to use.
Definitely.
So to land this plane, what's the last piece of advice you would have for the listeners for these types of emergencies? What do you think, Nuv?
Okay, so a take-home message for such foreign body ingestion pediatric ward: bottom battery lodged in esophagus require an emergent removal within 2 hours. Multiple magnets always necessitate undergo endoscopy or surgical consultation and removal. Most coin will pass spontaneously if the patient is asymptomatic, and they will be managed by observation and serial imaging.
Amazing.
And know your limits.
That should be the title of the podcast. Know your limits, especially for these emergencies. Any last thoughts, Daniel?
No, I don't have very much to add to that. I think, kids are fun. They keep you on your toes. They do silly stuff. Expect the unexpected. This is why we, sometimes we'll image kids. You're like, why are you imaging? And then you find things like this that you've ingested or not. So, using logic to pediatric presentations doesn't always work. So focus on the physiology, focus on the clinical signs and symptoms in front of you. I tell this with everyone: don't focus on the story. The story, especially in pediatrics, is often very innocuous or benign, and can result in significant presentations, or it can be very dramatic and the kid is totally fine. So really focus on what you see in front of you, what you can see on physical exam, what your vital signs are, etc.
Know your limits and don't focus on the story. And those are good pieces of wisdom. Well, this was so much fun. You're always welcome back. I hope you come back. I've learned so much. Like, I honestly mean this. I know the listeners will too. So thank you so much for your time today.
Thank you so much for hosting. This is great.
Yeah, thank you so much for having us.
This podcast is for educational and informational purposes only. It is not medical advice, does not establish a standard of care, and must not be used to diagnose, treat, or manage any medical condition or emergency. The content discussed reflects general principles that may not apply to every situation, system, or patient. Clinical practice varies by region, service, and jurisdiction. Always follow your local medical directives, clinical guidelines, protocols, and the instruction of your medical oversight or base hospital physician.